about non-lead modules you undertake. The core modules we're okay with because they're purely lead. What we're looking for is 30 seconds speaking to camera about what you liked about a particular module. Any of the optional modules you've done from Manchester. We just want 30 seconds or so of your perspective. And Dan and the IT team, the audiovisual team, will be on the hunt at lunchtime. So when they come, lunch out of camera view, 30 seconds, thank you very much, and they'll move on. If you don't volunteer, they'll probably disturb you again until you give up, okay? It would really help us. I would appreciate it, but you're not obliged. But if you wouldn't mind, it would really help us. All right? And with that, Dr. Muanguzi, the microphone is yours.
Thank you, Darren. Hi, everyone. My name is Pesh. I'm a senior lecturer in global health at the University of Manchester, and it's a pleasure to be here. So I'll be chairing this session, and I know we're quite excited to hear from Embu and Homa Bay. And without further ado, I'll start by inviting Team Embu to talk about management of diseases in the community. Please welcome Purity and Shem.
Thank you so much. How are we? Energetic, no stretches today. Yeah, so we are good, right? After the yeah, those who went for the safari said it was like ooh. And us were like climbing one rock after the other. But we are well, right? Yes, I'm glad to see you. Welcome to a new day, a new Monday. It truly feels like a Monday, right? Okay, welcome. So please put for me the one that talks about diabetes. So I just want to speak to you a little about how MSF strategized to deal with diabetes management in the primary health care, which was part of our NCD response. And on the first slide, yeah, this is a recap of a slide I showed earlier, just to show you on the numbers. So this is as at December 2021, when the project was closing. And we had the biggest percentage, 3,000 patients, 3,500 were pure hypertensive patients. Asthma, 680. And for asthma, we also managed children. So it was both children and adults. Epilepsy, of course, we had a lot of young children and teens who had epilepsy. COPD, you heard even from the presentation that it's not a very well recognized condition. Only now people are getting to appreciate and manage COPD separate from asthma. Hypertension and diabetes, comorbid, 700 patients. And diabetes alone, 800 or 900 patients. So we see we had a big number of patients who had diabetes. And mental health is very small, 18. And the reason for this, Anna asked me the other day, why such a small number? It's because we introduced mental health towards the end of the project. So starting from 2020, we had the mentorships for mental health. Earlier we had the development of the guidelines, then the mentorship, and a few patients were enrolled in care. And then we closed soon after, so we did not have a big cohort for mental health. So next slide, please. For type 1 diabetes, I told you earlier that we did not enroll type 1 diabetes children because we found this project in Embu level 5 that was very, very good. It was sponsored, I think, by Novel Nordisk, where they have this nationwide project. Peter mentioned that Embu was one of the first sites for them to implement the project. So this was well aligned. They give free insulin to the patients. Of course, they also gave a bit of education to the healthcare workers. And one of the best parts was the support group for children who are injecting insulin. And separately, they had support groups for the caregivers and for the parents of these children. But they also had therapy groups, especially during the holidays when children have closed. And so we saw that this is really nice, and we did not want to disrupt that. However, they enrolled children up to 11 years. So then once one got past 11 years, they would exit the project. And those are some of the people we enrolled in our project. We called them the mature type 1. So they're on insulin. They've gone through this nice project from MOH in EMBO level 5, but then they've been left out. So they would then come and join in our project. Next slide, please. So these are some of the things that MSF did for diabetes. One, we started with the mentorship, and we had this module specifically for diabetes, just like we had modules for all the other conditions. So the module was mentorship for MOH staff. At the primary healthcare level, remember, nurses and clinical officers, and community health volunteers for the community engagement. And with this mentorship model, we saw healthcare workers increase their confidence to manage diabetes at the primary healthcare levels. The practice before then was someone is tested either during the routine visit to the hospital, or they came to hospital unwell, or during the medical camps, and they were found to have an elevated blood sugar. And they were immediately given a referral note to go to EMBO level 5. So when they went to EMBO level 5, it was really difficult for them to get into the system, because they found the traditional MOPC, the medical outpatient clinic. So they have to get a booking for them to see the clinician or the doctor, and then they have to get their diagnoses and their treatments, and they have to keep on their regular follow-up in the EMBO level 5 hospital. For most of the patients, they took longer to get to hospital, as we said yesterday or the other day. And so it became, they were almost seen with advanced disease or with complications, or when it's really it was really difficult for them to manage. So what we saw is an increase in the confidence for the clinical officers and the nurses to speak about diabetes and to diagnose diabetes and manage. Of course, using the primary healthcare guidelines that we had developed earlier and that were in line with the teaching that we gave. And then for the lab, there was training and support from the lab staff, the MOH lab mentor, who also led the provision of the point of care machines that we talked about yesterday. We found MOH had were able to actually do a random blood sugar. The biggest challenge was the HB1AC, and so we provided those machines. We provide mentorship for the nurses, clinical officers, and lab staff where labs were available, and they were able to monitor the HB1Cs regularly for the patients. And one of the gold standard for MSF is to provide the drugs that are required for the patients to manage their conditions. So we had a big component of pharmacy support to MOH, and the drugs, as we said earlier, were all in line with the guidelines. So once patients were able to access their medications, then they maintained their sugars very well. We became part of the National Technical Working Group, because at that time, I think in 2019 is when we had the revision of the national guidelines for management of diabetes. So we included our NCD reference, we included our medical doctors. Some of the clinical officers from MOH were also involved in the discussions, just to share their experiences and what would be feasible at the primary healthcare levels. So that if the guideline would say, probably we have to do the HB1C maybe every 3 months, but in some of the health facilities, or because of the control of the patients, we have those who fit to just do it 6 monthly. Yeah, so, and of course it's a cost. So discussing the cost, discussing the experiences of primary healthcare levels, then their voice was put into the guidelines, and the guidelines were made simpler and easier to use for the primary healthcare level practitioners. And one of the biggest win for MSF and of course for MOH and the patients was lifting the insulin restriction. And this was done in 2019, 2020. Because earlier in the guidelines, insulin was only prescribed by the medical doctors. And then we see in level 3, level 2, we don't have medical doctors. So if a patient gets to a level where they have to use insulin, then they had to be referred to the EMBU level 5 hospital. Most of them did not go. Most of them did not receive the sufficient education to take insulin positively. And so what we found out is that they would just continue on their oral medications, their sugars are not controlled, and then that would end up to getting complications earlier. So with this restriction removed, then it became possible for us to have insulin initiated in level 3s mainly, because at level 3 we have the clinical officers, but not for level 2s. Patient education, insulin is viewed as the last stage of diabetes treatment in most of our local settings. So you have a patient who you've been managing on orals, and then tell them now the oral medication cannot control your sugar anymore. We have to put you on insulin. And they'll be like, oh, that's a death sentence. But it's not. And then for some of the patients, even in early diagnosis, they already have complications. So they have to go on insulin straight away, even if they're type 2 diabetes. And so a lot of community education to just demystify the use of insulin. And most of them accepted and felt better when their sugars were controlled on insulin. Of course, we know it's a bit difficult compared to the tablets, but with proper education, with proper support to the patients, we saw acceptance for people to use insulin. But we also were aware of the fact that there are some patients, even if they need insulin, then it's not safe for them to use insulin. So the acceptance of individuals with difficulties in administration of insulin. For example, the very old, yeah? Most of them, at an advanced age, most of them will also have sight complications or impairments, or may lack family support. So we have this old lady. She now requires to be transited to insulin, but the circumstances do not allow. She can't read. You've seen an insulin syringe. So they can hardly read, and you want them to inject something, point something, yeah? So we figured out that it would be more risky for them to use insulin, and we maintained those on oral medications, even when we knew that the control on oral medication was not very good. However, there was a lot of education, both and advocating with MOH for them to understand this, and discussing with the patients and the environments for them to see when the risk is too great, then we don't have to put them on insulin. We can still maintain them on orals. I think it borders the palliative aspects of care, maybe. And then we maintained an open referral system. One for the healthcare workers who did not feel confident to initiate insulin, but also for the health facilities that did not have the capacity to initiate insulin. So what happened is that we would manage the type 2 diabetes on orals to as long a point that they require insulin, and at that point they were referred to either level 4 or level 5 for the initiation. And once they were on a stable dose, then they would come back for their refills in the lower level facilities. So that worked very well for some of the facilities like the dispensaries, where the nurse felt, no, I'm not able to do the doses, I'm not able to just start on insulin. Can they go to a level 3? We have a clinical officer who can start them. And once they are stable, then we can do the refills from our facility, and they can always go for their 3-month checkup at the higher level facility. But one of the other tools we introduced was the self-monitoring of blood glucose. Because it was initiated as an outpatient, which is what we are encouraging now. During my time in school, insulin was always an admission. Someone had to be admitted just to be started on insulin. But now we are encouraging that we can start it as an outpatient practice. We gave, first of all, patients were educated. One, on how to check their blood sugars, what times to check their blood sugars, how to monitor their meals, and how to give themselves the insulin. And then they were given the forms, the self-monitoring forms, to go and check their sugars at home. And every time they checked their sugar, then they would chat. Of course, the form has the timings on when one should check the sugars. So they charted the sugars, and they brought this form back to the health facility after 1 week. So what the clinician did was to just review how their sugars have been in relation to their insulin and their meals. And where adjustment was required, then they would adjust appropriately. The bottom line is that for insulin, the patient involvement, I think the word active is very key. The patient has to be 100% involved in the decision making, in the choice, making the choice, and in their ability to actually inject themselves. Of course, there was education on where to inject, how to inject, when to detect for any dangers, and to come back to the facility immediately. So from an environmental perspective, we also issued patients with the safety boxes for them to put their needles, the used needles, and eventually they would bring these to the hospital for incineration and for disposal. So those are some of the steps, or those are the major steps over and above the normal practice that MSF took in Embu to see that patients' diabetes was well managed at the primary healthcare level with confidence and with good results. Thank you. So kindly put for me the second presentation. So Shem is going to talk about the CBO. So yes, the start of the community-based organizations in Embu. I want Shem to talk about the process because he is a patient. He's been in the process. I think for him, he joined the project in 2018. 2018, yes. Yeah? Yeah, the one that reached day 3. Yes, from, yeah. For me, when I talk about the CBOs, it takes me back to my family. I have twins. Yes, I'm a mother of 2 twins. My first twin is called Madiba. Yes, and my second twin is called Luther. So they've helped, the way I manage my boys has helped me actually manage the CBOs. Because one, they were born at the same time. We had the first CBO in Embu, where Shem is now the chairperson. And then a few months or days later, the second one was born, the one in Bere South. They are slightly different, but they're almost similar. So I always have this picture of my boys in the head when I'm speaking about the CBOs. You can't find it? Shem, you can talk. Yeah. So in the slides, not that one. In the slides that we have, I believe that you will be able to have them with you because they have big diagrams on the process of formation of the CBO, the process of formation of the CRP. We may not be able to discuss everything, but if you go through them at a later date, you may be able to get a lot more information. But Shem, would you talk about the formation of the CBOs, please?
Okay, good morning. I may go straight to the point. Well, as Purity said, I joined the MSA maybe in 2018. That's when I felt I should get myself to that group so that they may help me, and they have helped me. So now let me talk about the formation of our CBUs. Before the MSF left, they requested all the patients to form support groups in every facility, because in our CBO we have got 6 facilities. We have one which is called Kairori, and the others at the distant places. So maybe each at its own OMH premises, we were requested to form supporting groups. That is, those people who have got diabetes, maybe they may join with the one who are hypertensive. If not so, those one with epilepsy, they may join or form their group on their own. And I am a member of a diabetes group that is called Hypendia, which represents hypertension people, diabetes, and asthma people. That's called Hypendia. That's my group. Now, in my facility, that is one of the facilities which are there, 6 facilities. We have got 3 supporting groups. From each the other facilities, there are also supporting groups. When they come together, those groups now form what you call the CBO, community-based organization. Otherwise, it is formed of many supporting groups, formed by patients who are NCD patients. From supporting groups, we go now to the CBO. From every facility, we do elections. After elections, that we do elections after every 3 years. That's what our constitution says. Because every supporting group has got its own constitution. The CBO itself has got its own constitution, which governs the CBO. We cannot run a CBO without a constitution. That is what governs that. We normally do elections after every 3 years. So, when you are, for you to be a member of the CBO, 1, you must be a patient, an SNT patient. 2, you must be in a supporting group from your facility. So when you come to elections, every group or every facility, every group of supporting groups in the facility will produce 1 person to represent them in the CBO. That's the executive now. My group, my supporting group from Kanja, or my facility from Kanja will produce 1 person. The other facilities will produce 1 person. That is the elect from their place that we shall take you there to represent our interest in the executive. So in our CBO, we are 6 members from 6 facilities plus 1 member who represent people with who are asthmatic. So in our CBO group, you have got 6 executives. Those executives now are the one who are mandated to oversee how the CRPs, that is the smaller groups, are working. But before we get to that place, at the facility level, there are CRPs. That is community, that is revolving pharmacy. In our facilities, that is MOH, we have got facility for health for the MOH, and our facility is assigned. So when they are on drugs from the MOH, our patients normally get drugs for free from MOH. And the pharmacist who attend the patients at the MOH is the one who dispenses drugs in our facility. So we depend on the pharmacist from the MOH. So we normally keep our drugs in our revolving pharmacy, lock it up, because we are the managers, we are the custodians. We normally ensure that those drugs are safe. We are the ones who know when the drugs are, when the stock is going out, we replace from there our CBO. Normally, when we order drugs, the drugs comes from our supplier to our main CRP, that is at Kairori. From there, those drugs is dispatched to other facilities. In our CBO, as executive, we are the one who manages the other CRPs. And in Moso, we normally meet every month, maybe, and we normally meet on Wednesdays. First Wednesday of every month. That's when we meet to evaluate on some issues concerning our CRPs. Otherwise, that's the much I can tell them. But I wish you had that diagram here, we could have understood better. Otherwise, we are there managing the CRPs. We appreciate the effort made by MSF to bringing up those CBOs. We have got 2 in Embu. I am the chairperson in Embu, upper part of Embu. There is another one in Mbere South, which is called Mbere NCD CBO. They have got the same system as we have at our Embu NCD CBO. Thank you very much, Purity.
Thank you, Shem. I'm stepping down. So what we'll do is we still have a session tomorrow when we cover the exit strategy. We could quickly review the slides, and though the main topic will be the community revolving pharmacies, but I think we'll be able to share with you the slides on the formation of the CBO and the activities of the CBO, including NCD patient advocacy with MOH. Thank you.
Wow, I feel really bad. I still wanted to hear a bit more about the CBOs, but we'll have more time to engage with them. So please save your questions. We'll have them back for the panel discussion, and you can ask and get some more information. Now we welcome Team Homa Bay. George and Edward, are you ready? Let's welcome them as they come up to share something from the community as well.
Good morning. Okay, so I just have a very short slide, some 7 slides. I want to talk on, she talked of diabetes. I'll talk of what we do in Homa Bay for fixed dose, for hypertension. So, remember our Homa Bay project has got the differentiated service delivery model, and for patients to qualify, they need to be stable. Then there was from our MSF NCD guidelines I shared in the group, and forgive me, I know there are so many, there were 3. So from our NCD guideline, and also WHO 2021 recommended that hypertension patients to be put on fixed dose combination. That is for those maybe who are not medical, don't have a medical background. It's like having 2 drugs into one, such that the aim is to improve stability. So in Kenya, there is what we call the cascade of care for when you are running chronic diseases. So it does not have screening. Screening should be the one. So you can see from the global report on hypertension 2023 by WHO, it talks of the 4.8 million adults between 30 to 79 who have hypertension, only 40% have been diagnosed. So meaning that 60% of these patients who are estimated to be living with hypertension, they have not been diagnosed. You can see also out of these 40%, only 16% are treated. That is, they are on care. Maybe the others, they stopped being on care, or they absconded, or they were lost to follow-up. And of these, only 6% are controlled. So you see, this is a very big problem. You can look from, for your country, if you Google the global report on hypertension 2023, WHO, if you Google, you get the report. You can see like how your country fares. So for Kenya, this is how it is, which is a very big problem. So for us in Homa Bay, to achieve control, we introduced the fixed dose combination therapy. We use telmisartan and amlodipine. So it's recommended even in our MSF guideline. If you go inside, you'll see. You can go to the next slide. So this is what I was talking about. That is the algorithm, and you can see that this was adopted by MSF in 2021, and okay, you can call it the Sigo pill combination, or you can even call it the fixed dose, FDC. So in our project, we use the telmisartan, amlodipine, and the inclusion criteria, sorry, it's not visible on one side. The inclusion criteria, as I said, yes, Homa Bay, the HIV prevalence is high, and this means that some patients have a high pill burden. Because we normally have support groups for every conditions, so one of the challenge that was raised by hypertension patients, especially those living with HIV and TB, that they are taking a lot of drugs. What we can do is, because they know even for HIV management, fixed dose combinations are used. Then the other criteria we use is new enrolled patients, because we had a cohort and we were using SIGO agent pills. And then uncontrolled hypertension cases on monotherapies. And then remember I said, like, from our Homa Bay cohort, 24% of our patients are living with HIV. So currently, by January 2025, 893 patients were enrolled on fixed dose combination. This represents 70% of our hypertension cases. So, but this is also because we have like the 30%, some of them are stable on SIGO agent pill, and also they have not consented. So we had to have a criteria to start. You can move to the next slide. So also from our MOH guideline, they updated the Kenya Essential Medicine list. Like also in MSF, we normally have the essential medicine list, and it included the SIGO pill combination, the fixed dose combination. So, and this guideline, it gives, remember in our governance of MOH in Kenya, the national government develops the policy and also the guidelines. So the county government should adopt those validated guidelines. So the MOH included this, and our telmisartan amlodipine is also included. So you can move. And also the cardiovascular guidelines were also revised in 2025. You can move to the next slide. So these are some of the fixed dose combination that are available in our Kenya essential medical list. You can see also telmisartan, amlodipine. The only thing is it's expensive for a patient who uses one SIGO pill. It's 117 euros per year. So the other price, we got it from KEMSA. KEMSA is the Kenya Medical Supply Agency. It's a central MOH agency that procures drugs for MOH facilities. Can go to the next slide. And what are some of the successes? So from our patients during the support groups, and also we talked about that we have a community engagement team. One of the feedback we have gotten from our patients is a positive feedback, especially those living with other chronic diseases, because now it reduced the pill burden. But challenges, of course, there is that cost of SIGO pill combination that we are using, because MOH uses losartan. What is available in most facilities is losartan hydrochlorothiazide. So that's from our, as I was explaining, like we intend to open two new to support MOH, to open to like strengthen the care of NCD in 2 new sub-counties. So we want to go with what MOH is providing. But meanwhile, we were able to get a cheaper telmisartan amlodipine. I have not quantified the price. And also another challenge is the protocol still talks of SIGO agent pills. Of course, access to NCD care in Homa Bay, I explained, is a challenge because it's centralized and physician driven, and also the number of patient seen. MOPC only operates once in a week. The number of patients served by the doctors are very minimal, like not more than 25 per day. Can you go to the next slide? So the future, the way forward is, as I had explained, we are doing an operational research for it is targeting patients who are on fixed dose combination and those in the differentiated service delivery, the DSD. So thank you so much. So I'm going to call Edward to take us through the CBO. Thank you. Welcome, Edward.
Thank you so much. Allow me to appreciate those who went to my county yesterday. You did a good job. I hope you really enjoyed. Besides being a patient out here, I'm also a good ambassador of our county down there. So when you do something good, I need to appreciate. I will definitely go to the formation of a CBO. And going through that whole thing, there are two questions that I will handle. How did we start the CBO? And why did we start the CBO? In Kenya, starting a CBO, registering a CBO, there are guidelines. You cannot just wake up and register CBO. I will be coming to that. But you know, how did we happen to have a CBO? You know, when I found myself to be in the hospital suffering from diabetes, it was an individual thing. It was me. And then, how did it happen that we have this number? Because we started the CBO when we are 24 of us. We were not cooperated in the CBO, but we are the founder of the CBO. So the aspect of forming it was based on I was admitted and I was treated and I was now released to go back home. Through the MSF, they called some few individuals for a training because to the MSF they have seen there is a need of advocacy in terms talking about NCDs. So because they could not take the government, because they usually collaborate with the government, so they could not take and speak against some of the issues. So they were looking for some people that will now go to the village, because we are all coming from our villages. So they picked a rough number of 24. The main aim of these 24 was just to be trained on advocacy, just to go out and start talking about NCD, because it was a silent killer. And by that time, nobody was talking about it. So the MSF felt that they should bring the community, people that are patient, to start championing or talk about the NCD. And when we were trained on advocacy, then the idea of CBO came. Immediately after we have managed to be trained on advocacy, then 24 of us decided to, because we are coming from this different sub-county, so when we were all together at one place, we said, but we need to have an organization now to start championing or talking about NCD. Because talking about NCD as an individual, you might not get recognition. Because our county government usually will see you as just a person that is a busybody. But when you talk about the NCD as an organization, they will give you an ear, they will lend you, because you can now write the memorandum of memos and send to them. So we said, yes, we need to start a CBO. Then that comes with now what is required to form a CBO. Then if you look at the within the Department of how do you call it, social services in our national government, it is where you are supposed to go and register for a CBO. So before you could register for a CBO, you have to have a date with the ministry official to train you, to tell you, and to check on you, because you cannot register CBO without a constitution. The constitution will definitely give you the guideline. Because we are registered as NCD organization, our main focus will be basically on NCD. We will not be talking about other things. Those are some of the guidelines that you have to know from the government. And then, what is the criteria? What is how you are going to have your executive officials? What are the rules to guide you? So those are some of the things. And then we, through the MSF again, they did organize another training with the Ministry of Social Services, which took a day. And after that, now we are allowed to register a CBO. Then we did register a CBO. Now the second question is, after registering, why did we register the CBO? We have seen from the concept that one, CBO, NCD, was a new phenomenon in our area. So it was a silent killer, and people were not talking about it. So the main first aspect why we did register our CBO is to create awareness. Go out, talk about NCDs, and start doing some engagements, stakeholder engagements, which definitely we did. So after that, we started vigorously. By the way, with that we are only 2 years old. Our CBO is not, we have not been there for so long. We are 2 years old. But I can tell you we are doing so much. And we are very proud of ourselves. Because within those, I will tell you, highlight what we have been doing within those 2 years. So we don't have a fund like our colleagues who are given 5 million. We are not reached there yet. But now we started with why, and that is the awareness. So the awareness we have brought, we have tried to bring so many stakeholders. When we started, we were 24, but through that campaign of awareness and bringing people on board, right away we are 250 members. Within our constitution, it is simple. If you want to be part of us, confirm you are an NCD patient. If you are not an NCD patient, you are not part of us. Because maybe the interest will be different. You will be championing for another thing, but with us as a CBO, our concern is NCDs. So that is why we anchored that. So when we started, we found that there are so many gaps. The first engagement, we look at, do we have really drugs in our hospitals? Then the answer is no, we don't have. In fact, if you look at the budgeting system of our county, there is nothing like a budget for NCDs. Nothing. It is only a budget for HIV, but any NCD, there is nothing like that. So from there, after looking at that gap, we then start what we call stakeholder engagement. We started by engaging the locals, which actually help us to move to another level. Supporting groups, we go to religion leaders, we go to the peer groups, and then from there we started. So in our country there is something that we call, in Kenya, there is what we call, we have two levels of government. We have the national and we have the county. And within the county then we have the executive and then we have the assembly. So all these are stakeholders. Because the budget is usually being approved by the assembly, but is being proposed by the executive. The executive here is the governor and the CECs, the ministers of the governor. They propose, but those who approve the budget are actually the assembly. So these are two distinct stakeholders that you have to meet or talk with them. So there is an aspect of public participation. Whenever they have a circle budgeting. There is what we call public participation. They go to the how do you call it, to the villages to get the mind of this, what they want, the priorities in terms of development of what they want. So we started by engaging our people on the public participation. But I know that will be coming. So some of the things that we actually have done is that throughout our engagement, after realizing that there are gaps, no drugs in our hospitals, call them level 4, level 3, level 5, the referral, there is nothing. But we thank God. To us in Homa Bay, we are always referring to MSF as God sent. The God sent in the sense that me standing here, I don't buy drugs, but I go to my clinics and I get drugs from MSF. All these our 250 members, they don't buy drugs. They go to the 3 facilities, either the one that they are registered, and when their time comes, they usually go and get the drugs. So that is why we usually refer to MSF as God sent. Could it be that the MSF were not there? You could now imagine what could be happening to us, because no drugs in our hospital. So we started by engaging. Our first engagement was with the county pharmacist officer, and then we had an engagement with finance department and the clerk of the assembly. From what we came for our first engagement, they also accepted. But the one thing that is so fundamental that makes us very happy, those people who are patients of NCD, we have seen that if you are not a patient, you yourself, then you are a service provider. It means that either your dad or your mom is suffering from one of the NCD. So it was something that made us very hopeful that these people will understand, because I am standing here as a patient now, but you are listening to me. But in listening, it means in one way or the other you are being affected by NCD. So that help us now to, when we are engaging with these people, they are giving us an ear. And it was very easy for us. When we called for this meeting with the county pharmacist, because the county pharmacist is the one that is mandated for the procurement of all drugs for the county. So we had to call him and sit him down and have a discussion. He accepted that they have never been procuring for NCD. That is the first thing. Then we said, so you see, you are the people who are actually making our people to die. I think after that, because time is not on our side, they agreed to be procuring specific, they will be allocating some specific money for NCD. That was first breakthrough. And that is something that we are proud of. That is something that we are enjoying. I think because I was prepared and time is not on my side, I will leave it at that point. Tomorrow, I think I will have a little bit of time to give everything that we are doing. But we really appreciate for MSF. They have made us to stand tall today. And may God bless them wherever they are.
Okay, thank you, Edward. So, just to say is we have an advocacy manager from coordination who supports the formation of the CBOs, like trainings. Our communications manager also did trainings to them so that they're able to know. Because the way you talk to me is not the way you talk to the governor. And also if they give you 10 minutes, you need to know like what point to say and to get their attention. So maybe I forgot to say, like, for stability, because of our FDC is by year 2, 75% of our hypertension patients, they are stable because of that FDC. So thank you very much.
Thank you so much. I appreciate the teams for giving us two different perspectives We've heard from diabetes management and hypertension, and now we're going to something a bit different, which is still about management, and that's the misconceptions and myths and stereotypes in management of NCDs. Please welcome Peter to present this. Please welcome Peter.
Thank you. As you mobilize, it's okay. So we are saying as you mobilize patients to join CBOs and to be part of the project. Edgar, you can project. You find that we have misconceptions, myths, and stereotypes in the management of those NCDs. And here today, I just want to give contextualized examples from Kenya, and it's applied all over. Before we give practical examples, sometimes those terminologies are confusing. Where you need to talk about stereotypes, you find yourself talking about misconceptions. So what's a misconception? Next. A misconception actually is a misunderstanding or incorrect interpretation based on flawed reasoning or incomplete information. Like now, you can give an example of a misconception that hypertension is only a temporary stress-related condition. Imagine, that's a misconception. And many people believe it only arises during emotional upset. That when you have emotions, and you are likely to have hypertension, and it disappears after the upset. Like now, a 45-year-old teacher in Kisii stops taking antihypertensive medication once the school holidays begin, because believing that her pressure was only high due to workload. And she ends up hospitalized with a stroke because she thought hypertension was related to work. And at the end of the day, you end up getting a stroke. That's a misconception. Or another misconception we can say is that diabetes only occur in people who are overweight. This is false ring, ignores genetic and other risk related factors. Like now, Lean Farmer in Kericho, where we have tea planting, you refuse screening because she thinks thin people can't get diabetes. Actually, I also used to have that misconception until I got this knowledge, and now ignorance came out of me. She was later diagnosed with advanced type 2 diabetes after diabetic coma. That's a misconception. Or you can say that NCDs don't need treatment until symptoms do what? Appear. And you know that's the knowledge people have in the village. Why should I go to those people when I don't even see any symptom? When Dr. Mongar last month, was it last month we had a medical camp, or this month? Last month. Some village, people from the village came. They were diagnosed with some NCDs. Some of them started crying. I've come here, I was health, and now they're telling me I have what? An NCD. So they are blaming the screening. The people who are doing the screening. Those are misconceptions. You find that now silent NCDs like hypertension, sometimes you may not know that you have it, or early stage cancer often go unnoticed. Like in Migori, there was a case, a man skips checkups despite a family history of heart disease, thinking his health because he feels fine, and he suffers a fatal heart attack. That's a misconception. And then another misconception on asthma. We normally say that asthma is contagious. You know, that is misinformation about respiratory symptoms, causes fear. And you find that now children with asthma in rural West Pokot, that is in the Rift Valley, are excluded from school because teachers believe they can infect others. Why? Asthma is contagious. You know, that is a misconception. What about myths? When you talk about myths are widely held by false beliefs, often passed down through traditional or informal networks. It's something that you believe, but it's false beliefs. Like now we talk of cancer. We say cancer is a punishment from ancestors or due to witchcraft, which is so rampant in Western Kenya. Here and the other parts of Western Kenya, witchcraft is so rampant, like in Nigeria. We normally watch your movies. Those things do happen. They don't only happen in Nigeria, but also happen also here. So an explanation here is that seen in many African societies, it leads to stigma and a delay in treatment. When you say cancer is a punishment, it's caused by witchcraft. So someone may not want to go for screening. Like now, you find a woman in Nyamira with breast lump. They normally first consult a traditional healer who attributes it to a curse from her co-wife. It's the co-wife who has caused this. You know, that's a myth. And now she seeks medical help only after it is at stage 4. That's a myth. Another aspect is mental illness is caused by evil spirits. And you find that the explanation here is spiritual interpretations hinder proper care. You go to church, someone is telling you that this is a spiritual issue that needs to be cast away. These are demons. So you find a young man with bipolar disorder here in Kisii is taken to a prayer camp for exorcism. His condition worsens. Why? Due to lack of psychiatric support. You're dependent on prayers. You didn't go for checkup, and a psychiatrist could have helped you. Another aspect of myth that we can give is you can cure diabetes with herbal concoctions. Now, an explanation here is that men herbalists claim to flush out sugar from your body. So you find a diabetic market vendor in Kakamega County stops medication to use a traditional healer, tonic solid in the bus pack. Her sugar levels spiral dangerously. And at the end of the day, we are not able to help this person. Like what Purity said about epilepsy, is caused by eating chameleons. Someone can say that. You ate chameleons. That's why you have epilepsy. Or you stepped on charms. Someone had put something and now you jumped over or you just stepped on it. That's why you have epilepsy. So, an explanation is that long-standing superstitions, and it's in our mindset, especially in rural communities, hinders people to seek the right care. Like now in Taita Taveta, a boy with seizures is isolated and denied schooling because the villagers believe he was cast by a chameleon encounter. You see how those things are very complicated. On the aspect of stereotypes is oversimplified, fixed ideas about people. You have a fixated mind, you don't want to change, or conditions that may lead to prejudice and discrimination. Examples of stereotypes is one, only lazy people get diabetes. Have you ever heard of that? Only lazy people get obese or diabetes. So this ignores the genetic aspects that bring about diabetes, or poverty and structural food issues. So you find that an obese housewife in Nairobi avoids clinics because she's mocked as being lazy and greedy. So she hides her condition and suffers quietly. Again, like, men are too strong to suffer from what we call depression or anxiety. Like where I was born, even when we have a very serious problem, you don't show people that you have a problem. You cry inside. Men, we were trained, when we were being circumcised, we were trained to cry inside. So you die from inside. So what does that mean? Toxic masculinity. I'm a man. I don't want to expose myself. Undermines mental health care. So you find here a male banker, for example, in Eldoret, or here, delays seeking help despite panic attacks. You have panic attacks all the time because his family insists he's a man and he should man up. He later attempts suicide. I saw one of our colleagues, lecturers, dying, was it 2 weeks ago, Dr. Mech, because of bank loans. There's a lecturer who died. He had taken loans everywhere and treating these NCDs. At the end of the day, he didn't have anything. He just committed suicide. Still under stereotypes, a good example is whereby asthma is for weak children. Imagine. And you have that fixed mind. Asthma is for a weak child. And this one now, like when they are in school, it leads to bullying and a denial of treatment. Like if you go to Tharakaniti, a teenage boy hides his inhaler to avoid mockery in school because he avoids physical activities and suffers from attacks because of these stereotypes. And what you find is that once all this happens, the implication for public health and clinical practice is that it delays diagnosis and the treatment. Because if at all we have this kind of way of hiding our sickness, we are not going to expose ourselves for screening and all that. There is a delayed diagnosis and the treatment. And again, poor adherence to therapy. There is also the aspect of stigmatization and social exclusion. And then you as healthcare workers, you know, once this happens, there's worsening health outcomes. And because of what you are told in hospital and what you get in the village or at home, it brings the aspect of mistrust of healthcare systems. So what can be done as healthcare providers, as social scientists? And I'm happy you are nowadays accepting us social scientists to be integrated in healthcare systems so that we can be able to counter these misconceptions, stereotypes, and myths. One thing that we need to do is about community education. Once it's done well, it should be done well in a way that it's cultural, tailored, using the leaders and the local leaders, the CHVs that we have talked about, and also using the radio shows. Then we can have what we call myth-busting campaigns, whereby we are using, like Shem and his colleague, to use real-life patient stories. We do what we call role plays. We do skits and mobile theater, what Eunice was presenting here, using art-based models when it comes to raising awareness. And another thing that we can do is training health workers on cultural competence. Why is this important? It equips staff with tools to respectively challenge harmful beliefs. Then lastly, we can have school-based NCDs, literacy. How is this important? We can teach the young people about chronic illnesses early to break the cycle. If we are able to do this, I think we are able to manage NCDs in our work settings. Thank you.
Thank you so much. I'd like to invite all the other presenters to come up here and join me. Are you there? George, Purity, Shem, Edward? We're a bit short on time, so I'm going to request two things. I kindly request those who are asking questions to keep them short, and also those who are responding, please keep your response short. While we're at lunch, please take an opportunity to interact with our speakers, and you can ask them any more questions that you have. So I invite us to ask any questions. Okay, there is one here. And please tell us who you're directing your question to. Please help her.
Okay, thank you. Sorry, my question is for George. You were talking about in year 2, your patients showed stability on FDICs, and you were saying that one of your successes is that patients show that they prefer them. Are you able to show that your patients on FDICs are more likely to adhere, even though the cost is higher? Because this could perhaps justify the high expense.
Okay, thank you. So for the cost, it's MSF that bears the cost. So to the patient it's not affecting, and we are also able to get now a cheaper supplier at HQ level. For stability, for stability, there also the aspect of therapeutic education comes into play, because as I think from this conference we have heard, it's not only giving the drugs. So even a patient has a role to play to modify their lifestyle. Yeah, so that's why we have seen that stability is much faster for patients who are on fixed dose combination. Yes, but also it depends with also them playing their role. Yeah.
Thank you very much. My question is to the EMBU team. Regarding the challenge of cold chain with insulin, we know that it denatures under warm temperature. How did you go about actually mitigating those challenges with insulin in terms of maintaining cold chain, especially for those patients that usually go home with it? And then how do you ensure that it doesn't end up denaturing?
Thank you for your question. So for insulin, we have newer information that we can actually keep insulin at room temperature for about 28, 30 days. So what we do, while in the health facility, it is refrigerated. And then when the patient goes home with it, we ask them to preserve in cold areas of their house, but of course not necessarily in a fridge. Because then again at home, the fridges they have, most of them don't have, but for those who have, it's the food fridges, which would lead to contamination. So they would either look for a place that is cold, further from like the coldest room, under the bed, or in a place that is cold, but not necessarily in a fridge. And for 28 days, once it's opened, it's potent. After 1 month, if they still have something remaining in the bottle, then they will discard that and get a new refill.
Yeah, my question is for Dr. Peter. I was wondering what approaches you would recommend, for example, if your local leaders don't agree with the messaging or the treatments we are providing. What would you recommend, or did you have any practical examples where this was the case?
Okay, as I started when I was presenting, if you want to address the issues of misconceptions, stereotypes, and myths, you have to involve the local people from the onset. They understand the aspects of health and illness. Once they understand the concept of health and illness and now involve with the healthcare practitioners, they have to know how, the kind of message, the way they can package that message to the patient. Because at the end of the day, we say the patient should be placed at the community, not at the hospital. The patient belongs to the community. Once you have that in mind, you'll be able to use the really concepts. You remove the aspects of misunderstandings when you are addressing these issues of NCDs. Thank you.
Yeah, so I understand that part, but like for example, an example I experienced in South Africa is like where from local leaders, traditional healers, or president, they didn't agree with the messagings we had, for example, around HIV. And I'm wondering like how you would approach, like we try, of course, to get, but like there would
like okay, if I can respond it from the policy perspective, nowadays we have the indigenous policy being integrated in all that we do, whether in health and another programming, and it emphasizes on the application of the local knowledge in programming. So by doing that, such kind of interpretations can be handled at that level.
Thank you so much. And again, we go back and continue with stakeholder engagement. It doesn't end. We continue engaging with the stakeholders until we find some common ground. So I'll beg that we stop there for this session. Please, a warm round of applause to our speakers. They'll be with us for lunch, so you can continue interacting with them. After lunch, we'll be discussing issues to do with costs and money. And you know we need a lot of time to discuss things to do with money, not so? So I request you to have your lunch, and then let's be back here by 1:30. But also, for those who are going to be responding to some of the questions from the University of Manchester, they're up here, so you can just take a look at them in these few minutes and have an idea which of the ones you want to respond to as we go for lunch. So we'll close it here. Thank you so much to the presenters. Thank you all for being wonderful participants in this session. I welcome you to take lunch. Thank you.